Hello, I'm Dr. David Dodick from the Mayo Clinic in Phoenix, Arizona. Today I'll be discussing the evolving role of anti-calcitonin gene-related peptide, or CGRP, monoclonal antibodies for migraine prevention.
The following audio is part of a certified educational activity titled An Expert's Perspective on the Emerging Role of Anti-CGRP Monoclonal Antibodies in Episodic and Chronic Migraine Prevention. Access the entire activity and complete the post-test at www.peerview.com/NAB. Downloadable slides and practice aids are also available.
Now, migraine is a neurological disease, usually inherited, that affects more than 36 million people in the United States. Indeed, according to the World Health Organization, it's the third most common disease on the planet and the sixth most disabling in the world. As you know, it's more common in women. Usually that predilection to occur in females occurs during puberty, but it occurs 3 times more commonly in women than it does in men. Now, migraine has distinct stages. It's often divided up into prodrome, aura, headache, postdrome, and then a resolution phase. So the prodromal phase, patients may experience symptoms such as depression, sensitivity to light, yawning, cognitive dysfunction where they have trouble processing information, thinking straight, concentrating, and they may have food cravings as well. And these symptoms can last hours or they can last days before the actual onset of the headache phase. Prodrome probably occurs in about 2/3 of individuals with migraine. Then there's the aura phase, and the aura phase occurs in about 1/3 of individuals with migraine. The aura refers to reversible neurological symptoms that generally last between 5 and 60 minutes. And those neurological symptoms most often are visual, where patients may see zigzag lines or sparks or blind spots in their vision, and it tends to evolve and encompass their vision over time and then resolve. And it does so within about an hour. However, some people may have sensory aura, where they may have tingling in their tongue, in their face, in their hand. And then there's the headache phase. Now, the headache is usually often said to be unilateral, but 50% of patients can have bilateral pain. Patients will often describe that when the pain begins, it may be throbbing or it may be aching or pressure-like, and then only as it intensifies does it become throbbing. It's often moderate to severe in intensity. A characteristic feature is that it's aggravated by routine physical activity. It usually lasts 4 to 72 hours, and it may be accompanied by other features as well, such as nausea, unusual sensitivity to light, to noise, to odors, and also in some patients, dizziness, lightheadedness, neck pain. In fact, one study recently showed that cognitive symptoms, or the inability to process information, concentrate, remember, was almost as disabling as the pain itself. So migraine is certainly more than just a headache disorder. It is a neurological disorder characterized by a myriad of manifestations or symptoms. And then there's the postdrome, which is very characteristic, occurs in most patients, and includes symptoms such as fatigue, difficulty concentrating, lowered mood levels, depression, sometimes allodynia, or a sensitivity to stimuli that are normally not painful. So this postdromal phase can last hours, it can last days. So now I want to introduce you to a patient and share her story with you. This is Jennifer. She's a 33-year-old dental assistant and a mother of a 6-year-old boy. And in September of 2014, she presented to her family doctor with a moderate to severe headache located unilaterally in the left temporal area and behind the left eye. The headache persisted for about 2 days, despite initial treatment with ibuprofen, 800 milligrams, followed by a combination analgesic that consists of aspirin, acetaminophen, caffeine, about 12 hours after the onset. And Jennifer also complained of nausea and exquisite light sensitivity, even with normal ambient light. And so she would often wear sunglasses in the examination room. So Jennifer has a long history of headache dating back to her late teenage years. However, she couldn't remember any of her previous headaches being quite as disabling as the one she was experiencing at this time. She also has an intrauterine device for contraception that was implanted approximately 6 months after her son was born. Now, using the ID migraine questionnaire, Jennifer's family doctor had a high index of suspicion of migraine. The ID migraine questionnaire is a validated 3-question instrument that has a high predictive value for diagnosing migraine in clinical practice. So you ask the patient, during the last 3 months, have you ever had any of the following symptoms concerning your headache pain? Number 1, did you feel nauseated when you had headache pain? Number 2, did the light trouble you much more than when there is no headache? And number 3, did your headache ever limit your ability to work, study, or do something you needed to do for at least one day? There is a mnemonic by which you can remember these questions, and I call it the PIN mnemonic, where you pin the diagnosis. So P stands for photophobia, I stands for impairment, where their ability to work, study, or do something they need to do is impaired. And the N stands for nausea. So it's a very slick and simple way to remember these questions. In Jennifer's case, all 3 questions she responded yes to. So the positive predictive value, if you will, of this questionnaire in Jennifer's case is 98%. So there's a 98% chance that the headaches she's complaining of are migraine based on her response to these questions. Now, her doctor prescribed sumatriptan 50 milligrams and an antiemetic as her acute therapy. And she began to experience pain relief about 2.5 hours after taking her medication. Her symptoms completely resolved after about 24 hours. So between September 2014 and August 2015, Jennifer experienced more than 5 headaches of similar symptomatology and duration, but with increasing severity and frequency. So her initial attack frequency was about 2 to 4 attacks per year, but they increased to 1 to 2 attacks per week between mid-July of 2015 and August of 2015. So when she presented to her family doctor in September 2015, she reported her 2 most recent headaches didn't completely resolve after several hours after treatment with her acute treatment regimen. She also missed 1 day of work during her 2 most recent headaches because they were severely disabling. So after listening to Jennifer, her doctor increased her sumatriptan dose to 100 milligrams and referred her to a neurologist for additional evaluation and follow-up. Now, by the time Jennifer presented to the neurology clinic in December of 2015, she had been experiencing headache approximately every 6 days, or about 1 or more per week, since the middle of September. Fortunately, the 100 milligram sumatriptan tablet had made these headaches less disabling, and they shortened the duration. Her physical and her neurological examinations were normal, as well as previously ordered laboratory tests, and her SNOOP assessment was negative. And this SNOOP assessment is for worrisome features that may signify an underlying secondary headache disorder. So at this time, we should stop and ask the question, what is Jennifer's diagnosis? Does she have episodic migraine with aura? Does she have episodic migraine without aura? Or does she have chronic migraine? And for the answer to that question, we should look at the International Classification of Headache Disorders, Volume 3, Diagnostic Criteria for Migraine with Aura. So first, the patient needs to have 2 attacks fulfilling the following criteria. And that's important, so you can't actually make a diagnosis of migraine with aura just based on 1 aura. They need to have at least 1 or more fully reversible aura symptoms, and we've talked about several of these earlier: visual, sensory, speech or language, motor, brainstem, retinal. They need to have at least 2 of the following 4 characteristics. So at least 1 aura symptom spreads gradually over 5 minutes, or they have at least 2 symptoms that occur in succession. So what that means is that they may have a sensory aura that spreads over the course of at least 5 minutes, or a visual aura that starts up in the periphery of the visual field and then moves centrally, so it spreads. Or they have 2 symptoms that occur in succession. So first there may be a visual aura, and then the sensory aura may develop. Or each individual aura symptom has to last 5 to 60 minutes by definition. At least 1 aura symptom is unilateral, so for example tingling or numbness, And aura is accompanied by or followed within 60 minutes by headache. And most importantly, it's not better accounted for by another ICHD3 diagnosis, and TIA has been excluded. Now, let's look at migraine without aura criteria. So the patient needs at least 5 attacks fulfilling the following B through D criteria. Again, it's important that it's 5 attacks because a patient who presents, let's say, to the emergency room for the first time or to your office for the first time with a headache that seems and sounds like migraine, but they've never had an attack like it before, you can't make the diagnosis. The attacks, as we said earlier, last 4 to 72 hours if untreated or unsuccessfully treated. The headache has at least 2 of the following characteristics: a unilateral location, so one-sided, a pulsating quality, it's moderate or severe in intensity, and it's aggravated by or causes avoidance of routine physical activity. And during the headache, they need to have at least one of the following, so nausea or vomiting, or photophobia and phonophobia. And again, E, not better accounted for by another ICHD3 diagnosis, so it assumes that you've excluded secondary causes. Now for chronic migraine, the headache just needs to be present 15 days per month for at least 3 months. And the headache can be of any variety. It can be tension type or can be migraine-like. The headaches have to fulfill those B through D criteria for migraine without aura, and or the B and C criteria for migraine with aura. And on 8 days of the month, for at least 3 months, at least these criteria need to be met. Criteria C and D for migraine without aura, criteria B and C for migraine with aura, or it's believed by the patient to be migraine at onset and relieved by a triptan or ergot derivative. And again, not better accounted for by another ICHD3 diagnosis. So what is Jennifer's diagnosis? In this particular case, it's episodic migraine without aura. She has less than 15 headache days per month. She's having 1 to 2 per week on average. There's no history of aura with her attacks. She's had at least certainly 5 attacks that fulfill B through D criteria. And it's not better accounted for by another ICHD3 diagnosis. In other words, the physician carefully went through that Snoop mnemonic. So Jennifer's neurologist discussed the diagnosis of episodic migraine without aura with her. There was no change made to her acute therapeutic regimen. She was encouraged to keep a headache diary and a journal to help track her attacks and to identify any potential triggers. The time of headache onset. With the diary, she can track duration and severity, the response to acute treatment, in other words, time to relief, time to pain-free, and time to feeling back to normal or time to return to normal function. And then finally, the presence and duration of prodrome or postdrome. So although Jennifer's headache pattern was somewhat stable, the frequency in which they were occurring was affecting her quality of life, and she asked if there's anything that she could do to reduce the number of headache days she was experiencing each month. So here are the indications for preventive treatment in patients who have migraine. Regardless of frequency, if one has recurring migraine that significantly interferes with the patient's quality of life, despite the fact that they may be taking acute treatment that's effective, that's an indication for prevention. Another indication for prevention is if they can't take acute treatments because of contraindications, or there are troublesome side effects, or if they simply fail to work. Another indication is if they're overusing acute medicine. So a patient, by definition, who's using an acute medicine 10 or more days per month to treat migraine, that's acute medication overuse. And those who overuse acute medications are more than 20 times more likely to develop chronic migraine. Very frequent headaches, at least once per week or more, is an independent risk factor for progression and an indication that a conversation should be had with that patient to think about starting a preventive medication. If it's the patient's preference, regardless of the physician's perception of how disabled the patient is, if the patient prefers to be on preventive therapy because of the anticipatory anxiety and because of the unpredictability of the attacks and the way that interferes with their life, that could be an indication for prevention. And then special circumstances. So if a patient has hemiplegic migraine, and I've seen patients who have hemiplegic migraine where they remain paralyzed on one side of their body for weeks or even months at a time. Now, the American Headache Society and the American Academy of Neurology has established and published evidence-based guidelines for the prevention of episodic migraine. And based on the levels of evidence, and based on the number and quality of the randomized placebo-controlled trials, they've divided these medications up into level A, where medications have established efficacy, and they should be offered for migraine prevention. And the drugs in level A category are divalproic sodium or sodium valproate, topiramate, metoprolol, propranolol, timolol, and rovatriptan. But the triptan, it should be noted, is level A based on its ability to prevent menstrual migraine. And then there are drugs in level B, where they're probably effective based on the evidence and should be considered for migraine prevention. And they are amitriptyline, venlafaxine, atenolol, nadolol, aratriptan, and zolmitriptan. And then there's a few medications in level C, and they may be considered for migraine prevention. Now, there are issues with the available preventive therapies for migraine, and I face these issues every day in my clinical practice, including this morning. So although a wide array of medications can be used for episodic migraine, here are some of the issues. Currently in the United States, not one of the available therapies that's approved, or even not approved but used frequently, were developed specifically to prevent migraine. As you saw, we have a group of medications that are antihypertensive medications, we have anticonvulsants, we have antidepressants, we have antihistamines that were developed and designed to treat other diseases. They weren't designed or developed to treat migraine. There are efficacy, safety, adherence, and drug-drug interaction issues for a substantial proportion of patients. And about 1 in 5 migraine sufferers is forced to suspend pharmacological prophylactic treatment because of adverse events. So fortunately, there are new and very promising treatments that are in the later stages of clinical development or have actually completed their pivotal trials for episodic migraine prevention. And the thing about these promising treatments is that they were developed and designed specifically for migraine, because we know enough about the biology and the underlying pathophysiology of migraine now that we've been able to identify very specific and selective treatment targets and design either small molecules or antibodies to go after those targets. Now, the most promising emerging treatment target is calcitonin gene-related peptide, or CGRP. So what's its role in migraine pathophysiology? Well, during the last decade, blocking CGRP has emerged as a very promising mechanism for the prevention and indeed actually the acute treatment of migraine. CGRP is a 37 amino acid neuropeptide that is widely distributed throughout the central and peripheral nervous system, and it exists in alpha and beta isoforms. The main isoform expressed in the trigeminal system and in the central nervous system is alpha CGRP. And it's been localized of particular importance to migraine in unmyelinated C fibers and small myelinated A delta fibers, both of which are involved in pain transmission. There are 3 principal lines of evidence which support the hypothesis that CGRP plays a prominent role in migraine pathophysiology. Number 1, during spontaneous migraine attacks, CGRP levels actually rise in the blood. Number 2, after an individual is treated with a triptan and their pain is relieved, CGRP levels decline in the blood. And number 3, when an individual with migraine is intravenously infused with CGRP, it will trigger an attack that's indistinguishable from their spontaneous attacks. So now we have 4 monoclonal antibodies that have been developed to target the CGRP pathway to prevent migraine. 3 of them, fremanezumab, galcanezumab, and eptinezumab, target the CGRP ligand itself, the peptide itself, whereas erenumab targets the CGRP receptor. So we'll first look at a phase 3 study for fremanezumab that was evaluated for the prevention of episodic migraine. This is one of the HALO studies. 875 patients were randomized on a 1-to-1-to-1 ratio to receive subcutaneous injections of fremanezumab 225 milligrams as a monthly dose for 3 months, or fremanezumab 675 milligrams at the initiation followed by placebo for months 2 and 3, or placebo at the onset and then at months 2 and 3. Fremanezumab given monthly in this trial improved the average number of migraine days relative to baseline by 41.6% for the duration of the trial. So there was a reduction on average of 3.7 migraine days per month in the active treatment group compared to minus 2.2 for the placebo group. The quarterly subcutaneous dose also yielded highly significant results for the decrease in migraine days. 3.4 days reduction, or 37%. Both dose regimens improved migraine in subjects on stable doses of other prophylactic medications. And the reason why that's important is that if and when these biologics become available for clinicians to use in clinical practice in their patients, it's likely that those patients coming to our practices are going to be on prophylactic medications at the time. The second antibody evaluated for episodic migraine prevention is galcanezumab, and there were 2 phase 3 studies, the EVOLVE-1 and the EVOLVE-2. These were 6-month international trials that evaluated the safety and efficacy of 2 doses of galcanezumab administered subcutaneously each month. 2 doses studied were 120 milligrams and 240 milligrams. In both studies, patients treated with galcanezumab experienced a significantly greater decrease in the average number of monthly migraine headache days compared to those who were treated with placebo. The third antibody I wanted to talk about is an antibody known as eptinezumab. Now, this differs from the previous 2 antibodies because it's delivered intravenously. So this is the results from the PROMISE-1 study in episodic migraine that evaluated the efficacy and safety of eptinezumab 300, 100, and 30 milligrams administered by IV infusion once every 12 weeks through week 24. The study continued for an additional 2 doses every 12 weeks with a follow-up through week 56. The study enrolled 888 patients diagnosed with frequent episodic migraine. The primary endpoint demonstrated statistically significant reductions in monthly migraine days from baseline over weeks 1 through 12 by an average of about 4.3 migraine days per month for the 300 milligram dose, 3.9 days per month for the 100 milligram dose group, compared to an average of about 3.2 days for placebo. And finally, the fourth antibody, which is also a subcutaneous antibody, is arenumab. Now, you'll recall that this antibody differs from the other 3 because the other 3 target the ligand, while this targets the receptor. So this is the STRIVE trial designed to evaluate the efficacy and safety of arenumab in the prevention of episodic migraine. 955 adults were randomized in a 1:1:1 ratio to subcutaneous monthly injections of placebo, arenumab 70 milligrams, or aranumab 140 milligrams for a period of 24 weeks. And here are the results of the STRIVE trial. So patients reported 8.3 mean monthly migraine days at baseline and experienced a 3.2, 3.7, and 1.8 day reduction in the 70, 140, and placebo groups, respectively. A 50% reduction in mean monthly migraine days, in other words, the responder rate, was achieved by 43%, 50%, and 27% in the 70, 140, and placebo groups, respectively. And the monthly acute migraine-specific medication days were reduced by 1.1, 1.6, and minus 0.2 days in the 70, 140, and placebo groups, respectively. And positive results were also reported in the Phase 3 ARISE trial, which was another episodic migraine prevention trial with aranumab in parallel with this study. The data that we tend to use in practice and we tend to communicate to our patients is what's the likelihood they're going to respond? And we often determine clinical meaningfulness of a treatment based on this responder rate. So what I'm showing here is in the episodic migraine trials, the results from the phase 3 trials that have evaluated the efficacy of each of these antibodies. And what we're looking at here is the percentage of patients who had a greater than 50% reduction in mean monthly migraine days. And as you can see, depending on the antibody, depending on the trial, anywhere from in excess of 40% up to 60% of patients had a greater than 50% reduction in the average number of monthly migraine headache days. So that's a significant result. So let's go back to Jennifer now. So after discussing potential preventive treatment options with Jennifer, a shared decision was made to commence topiramate for headache prevention. And she was started on a typical starting dose, which is 25 milligrams per day for 1 week, and the dose was titrated by 25 milligram increments each week until a target dose of 100 milligrams was achieved. From December 2015 to March of 2016, she experienced a decrease in headache frequency and severity. Frequency decreased by about 40%, and attacks were mild to moderate and responded faster to acute medicine. And we tend to see that in practice. And with effective prevention, we find that there's a reduction in not only the frequency, but in the intensity and duration. But although the preventive treatment appeared to be working well, Jennifer did experience tolerability issues with topiramate, including trouble finding words, trouble concentrating, and trouble expressing herself. And that's a relatively common adverse event with topiramate. So in March 2016, Jennifer was switched to propranolol, starting at a dose of 60 milligrams and titrated to a dose of 120 milligrams over the course of 2 weeks. And a follow-up visit was scheduled for June of 2016. Jennifer's headache pattern remained stable, about 4 to 6 headache days or migraine headache days per month, through her follow-up visit in June 2016. However, she felt fatigued, it was more difficult to exercise on propranolol, but it was keeping her frequency and severity relatively stable. And beginning in mid-July of 2016, her headache frequency began to increase over time again to approximately 12 days per month through December 2016. Jennifer's last headache at the end of December 2016 actually resulted in an ER visit because the pain was so severe and debilitating, and it had lasted for 4 days, and clearly was not responding to the acute treatments that she was using at home. And when she presented to her neurologist in early 2017, she was almost in tears because she was having more frequent migraine, more disabling migraine. And when the neurologist reviewed Jennifer's headache journal, it revealed that there was no clear triggers or stressors. She had new headache symptoms of phonophobia and osmophobia and scalp sensitivity. So she was now increasingly sensitive to her environment. Sound was more bothersome, smells were more bothersome, and she was now reporting cutaneous allodynia, or that scalp sensitivity. And that, by the way, is also an independent risk factor for progression. She developed increasingly severe nausea during the previous 2 months that resulted in her vomiting up her acute therapy shortly after taking it, and a loss of appetite that would persist for 1 to 2 days even after the resolution of her headache pain. And Jennifer's sumatriptan antiemetic regimen that she was using had lost much of its effectiveness. She often needed to redose, if and when it even did provide partial relief. So her neurologist rightly became increasingly concerned about Jennifer's risk of progressing to chronic migraine. She's demonstrating a number of risk factors. Her acute medicine is becoming increasingly less effective. She's using more of it and potentially getting into a risk of developing medication overuse headache. And that's of concern to her neurologist because once patients progress into chronic migraine, it may be more difficult to manage them and to get control of the situation. So there's a dearth, really, of effective therapies for chronic migraine prevention. Onabotulinum toxin A is currently the only therapy in the U.S. approved for chronic migraine prevention. Topiramate has been studied. There are 3 placebo-controlled studies with topiramate that have shown it to be effective in chronic migraine for prevention, but it doesn't yet have a formal indication in this setting. Similar to episodic migraine, Of course, neither of these therapies were developed specifically for chronic migraine prevention. Unfortunately, as we talked about, these anti-CGRP monoclonal antibodies have been investigated for chronic migraine prevention, have been shown to be effective for chronic migraine prevention. Let's talk a little bit about the chronic migraine studies. So this is the HALO chronic migraine study, which is a phase 3 study of fremanezumab for chronic migraine prevention. Patients treated with fremanezumab experienced statistically significant reductions in the number of monthly headache days of at least moderate severity compared to placebo during the 12-week period after the first dose. And that was true for both the monthly dosing regimen, where the average reduction was 4.6 days, and the quarterly, where the average reduction was 4.3 days, compared to placebo, which was minus 2.5 days. Injection site pain was the most commonly reported adverse event, and there were no treatment-related serious adverse events that occurred. For galcanezumab for chronic migraine prevention, there was the REGAIN study. The results showed an average reduction of 4.8 days and 4.6 days for the 120 and 240 milligram dose groups, respectively, compared with 2.7 days for placebo, both highly statistically significant differences. Additionally, patients treated with galcanezumab experienced a significant improvement compared to placebo on several pre-specified secondary endpoints, including responder rates, as well as measures of daily activities. The phase 2 trials evaluating eptinezumab for chronic migraine prevention are reported here. So this is eptinezumab. Again, just to remind you, this is the intravenously administered antibody that targets the ligand. So patients were randomized to receive a single intravenous dose of eptinezumab 300 milligrams, 100 milligrams, 30 milligrams, 10 milligrams, or placebo. At baseline, the number of migraine days per month were between 16.2 and 16.5 days. For the primary endpoint, which was at least a 75% reduction in migraine days for the entire 12 weeks, there was statistically significant differences seen for the eptinezumab 300 and 100 milligram dose groups. So 33% and 31% of patients in each of those dose groups respectively achieved a greater than 75% reduction in mean monthly migraine headache days over that 12-week duration, compared to 21% in placebo. The differences with the 30 and the 10 milligram dose groups were not significantly different than placebo. So this is the phase 2 trial that evaluated the efficacy and safety of erenumab in patients with chronic migraine. So 667 adults with chronic migraine were randomized in a 3:2:2 ratio to monthly subcutaneous placebo injections or injections of 70 or 140 milligrams of erenumab. So the results were that patients experienced a mean of 6.6-day reduction in mean monthly migraine days in each of the 70 and 140 milligram dose groups versus a 4.2-day reduction in the placebo group. 40% and 41% in the 70 and 140 milligram dose groups, respectively, experienced a 50% reduction in mean monthly migraine days compared to 23% for placebo, and a 3.5-day and a 4.1-day reduction in acute migraine-specific medication use compared to a 1.6-day reduction for placebo. And all of these results were significant. And I think you're getting the sense from presenting all of these phase 2 and phase 3 studies, whether episodic or chronic migraine, that the tolerability profile of the active drug, regardless of which antibody it was similar to placebo. So again, clinical meaningfulness can come from establishing the percentage of patients who have a significant change when put on therapy. So we talk about responder rates in clinical practice. And so when I'm sitting with a patient, I will say to a patient that in clinical trials, X percentage of patients had a greater than 50% reduction or a greater than 75% reduction in the frequency of migraine headaches. And in the chronic migraine trials, both phase 2 and phase 3, which each of these antibodies, we see a significant difference compared to placebo in responder rates, ranging from about 25% up to 60%. So that's a substantial impact on a substantial number of patients with a significantly disabling disease. So in summary, monoclonal antibodies targeting the CGRP pathway represent a novel approach to prevention. Indeed, if and when these become approved and available, they will be the only mechanism-based, targeted therapy specific for migraine prevention. That's good news for patients because when you have a treatment that was designed specifically to target the underlying pathophysiology of the disorder, that means that it's likely to be effective, more effective than currently available treatments, and likely to be better tolerated. Thus far, the tolerability profile of the monoclonal CGRP-targeted antibodies appears very favorable. Indeed, there are really no unique or serious treatment-related adverse events that have appeared in any of the phase 2 or phase 3 trials. If approved, this attribute actually should enhance patient adherence and improve long-term outcomes. Patient selection is going to be very important, especially in the episodic migraine setting. There's emerging evidence that they're effective when added to existing preventive medications. That's important because quite likely, if and when these emerge, approved, and are available, we're going to be using them in patients who have failed multiple prophylactic medications or who are on one or more prophylactic medications. So these patients, such as the patient in our story, Jennifer, they potentially stand to benefit the most from a novel migraine-specific medication. And in the setting of chronic migraine, they will likely provide patients with a much-needed increase in the number of therapeutic strategies that we have available for headache prevention. It's an exciting time for patients, and it's an exciting time for clinicians who provide care to these patients.
This activity has been jointly provided by Penn State College of Medicine and PVI, Peerview Institute for Medical Education. Thank you for listening. Download materials and complete the post test for instant credit at www.peerview.com/NAB. This activity is supported by an educational grant from Teva Pharmaceuticals.